Dear friend, dear patient, and maybe dear colleague, it's my pleasure to have the net lectures today on pelvic neuropathy. My name is Professor Possover. I'm a neuropelveologist and gynecologist. And during the last video, we were talking on the overactive bladder and especially on the hypersensitivity of the bladder, which is due to an irritation of the pelvic nerve involving bladder function. So today we'll go a little bit on a high level of the pathology of the pelvic nerve. And the topic from today is not just to talk on the urologic condition due to pathology of the pelvic nerve, but you as a patient, how to recognize that you're suffering from a pelvic nerve condition, that you're suffering from pelvic pain, and not like what I heard every day in my consultation, I'm pain because of my endo. Endometriosis is not responsible for all the pain. You have to keep in mind that if you have pain, it's not because endometriosis in your brain or another issue, but because the pelvic nerve brings the information to your brain, I have pain. And the pelvic nerve can bring all kind of information, not just the pain, and can bring this information from several pathologies. So let's talk about pelvic neuropathic pain. And to understand neuropathic pain, then we have to come back again to the anatomy, the anatomy of the function of the pelvic nerve, because pelvic nerve not just brings information of pain to the brain, but control several functions. The first one, pelvic nerve control what we call vegetative or involuntary pelvic function, like urinary function, intestinal function, and sexual function. So for the bladder, for example, the bladder is in charge, the vegetative nerve in charge to bring the information to the brain when the bladder is full and when you have to go on the toilet to empty your bladder. For the bowel, it's exactly the same. And by the through, for the sexual function, the vegetative nerve are in charge of the mediation of arousal, orgasm, and erection. Organ mean even in men, ejaculation. Then you have the second function, the control of the motor muscle function, means the red muscle of the lower back, the bottom, and the lower extremity, and of course, the pelvic organ as well. So it controls the external urethral and anal sphincter as well, the continence of your pelvic organ. And then the third function is to provide all sensory information to the brain, not just the information of pain, but the information is my foot is cold or warm, all genital-anal feeling, burning pain when you have an issue, but also all information coming from the bottom, from the lower back, and from the leg. So, and all these nerves are divided in two groups. You have on one side the vegetative nerve, and on the other side the somatic nerve. The vegetative nerve are sensoric and motoric. Motoric means brings the information down from the brain to the lower back, the pelvis, and the lower extremity, and motor to the brain. But all these functions are involuntary. They are doing by themselves. While the somatic nerve, which are in charge of the red muscle, are voluntary function. That means when I think I want to stand up and to walk, this function is the somatic nerve are in charge of this function. So, and these both group of nerve are working in both directions. In direction to the brain is what we call afferent nerves. In direction to the periphery, to the leg, to the pelvis, these nerves are called the efferent nerve. And to understand pain, you have to understand that. So you have an issue of the vegetative nerve, the patient will suffer from vegetative pain, or what we call visceral pain. You have an issue with the somatic nerve, you will suffer from somatic pain. And the pain in the description by the patient are completely different. On the left, you have the visceral pain. The visceral pain, the typical visceral pelvic pain is, for example, endometriosis. It's a pain located in the whole lower abdomen, is poorly localized, with some radiation because the visceral nerve are not going down but up by following the back. So you will have low pelvic pain with radiation to your back. All patients with endometriosis are suffering from low abdominal pain and will explain I have back pain as well. These pain are dual in nature, and because we are talking from the vegetative nerve system, once you have an irritation of this vegetative nerve system in some area of your body, the whole vegetative nerve system will get inflamed. That means you will have, even if the problem is in your pelvis, you will have an overactivity of the whole sympathetic nerve system in the rest of your body. And as a doctor, if we are specialized in neuropelveology, you will be able to recognize the overactivity of the vegetative nerve system by reading the patient. The patient first will get pupil dilation. So if you look the patient in the face, the black in the eye, the pupil is dilated. And because the overactivity of the sympathetic nerve system decrease the salivation in your mouth, you will get a dry mouth and you will have dry lips. And then you will have an overactivity of your brain. So you will have malaise, oppression, even syncope. You will be very, very tired. One bad word in your family and you will explode. You will have tachycardia, nausea, vomiting, anxiety, diaphoresis. That means your hand will be very wet and cold, and you will start to sweat the axilla, even if it's cold for you. On the other side, you can suffer from a somatic pain, so a pain bring to the brain by the somatic nerve, and this pain is usually completely different. It's a somatic pain described as an electrical shock or like fire. Patient said, I have burning in my vulva, or my pain from the lower back is burning and is going down in my leg, or electrical shock, as I told, or tingling, for example. That is a typical kind of description of somatic pain. These pain are well located. The patient will not explain, I have pain everywhere in my low abdomen. The patient will be able to localize the pain origin with one finger. She will say, I have pain here. And then, in the main difference between the visceral nerve, the somatic nerve are going down. So the patient will get caudal or radiation going down. And that's the reason, for example, when you're suffering from a discus hernia and you have a sciatic pain, the pain will start in your back, lower back or in the bottom, but the pain will go down, even sometime to the foot and the toes. And that is a typical kind of somatic pain. The patient will be able to describe the exact location of the starting pain and the radiation down along the leg or in the pelvis. And because these nerves are involved in voiding function of the rectum, of the bladder, and sexual, if the patient presents some damage of the nerve, the patient will have behind this pain dysfunction, disorder, trouble of the pelvic organ with, if the nerve are overactivated, for example, overactive bladder, or is the nerve on damage? The patient will have difficulty to empty the bladder, will have maybe even to use a catheter to avoid the bladder. For the rectum, even the same between diarrhea and irritabilis, colon irritabilis, and on the other side, constipation. And for the sexual function, loss of erection, for example. And of course, because the sciatic nerve is located in the pelvis, if you have an issue of the sciatic nerve behind sciatic pain, maybe you will develop some dysfunction of your walking function. You will get difficulty to walk. So, the cause. So, the typical cause for pelvic visceral pain in women is endometriosis, for sure. That is a very, very frequent pathology in women. In the literature, you will find maybe 10-15%. I think it's even more than 40% of the women. And when a patient is coming and report, I have pain every month during my men's bleeding. Of course, I cannot say, yes, you're suffering from endometriosis. But I cannot say, no, you're not suffering from endometriosis, because most of cases, you will even need maybe a surgery to get some tissue to bring them under the microscope. And the pathologist will tell you, yes, you're suffering from endometriosis. By the way, endometriosis don't mean you will have, in any case, difficulty to get pregnant. No, it's not like that. Endometriosis may induce some trouble in 30% of the patient to get pregnant. But to say, with endometriosis, I will never get pregnant, that is wrong. It's not like that. So remember that the vegetative nerve are in charge from the uterus, endometriosis, but from the bladder as well. So pelvic pain will be also produced when patient is suffering from a bladder hypersensitivity. Patient will have to go very often on the toilet. She will have to go suddenly of the toilet to pee, but the urination will be painfully. The same for irritable bowel syndrome, when patients have to go very often on the toilet because of diarrhea. And in most of the case, if we are not finding an etiology in cause, a cause in women is easy to say is because of endometriosis. But if we are not really finding an endometriosis, the diagnosis number one will be chronic pelvic pain syndrome, or PMS, premenstrual syndrome, or bladder pain syndrome, and so on. And of course, there are also pathology, real pathology, for example, infection, UTIs, or infection of the uterus, of the tube, or your ovarian. They are all cause for pelvic pain. And the somatic pain, as I told you, the somatic nerve in charge of the bladder, of the sexual and rectal function, of the walking function. So you will develop a mix of what we call orthopedic pain, with lower back pain, buttock pain, sciatic pain. You will have pudendal pain, genitoanal or intestinal pain, sexual pain, and you will have issue with the bladder, overactive bladder, or hypersensitivity of the bladder. And the problem in the daily work as a gynecologist, orthopedist, or urologist, if you see a patient with back pain as an orthopedist, you will evoke like a pathology like spondylolisthesis, hip problems, spinal stenosis, facet stenosis, and of course, if you are suffering from a sciatic pain, the diagnosis number one will be a discus hernia. Or if you're going to a physiotherapist, it will be a piriformis syndrome or myofascial syndrome. And if you go to the gynecologist, he will tell you maybe you have a vulvodynia, vestibulitis, an infection of the vulva, or a lesion of the vulva. And the urologist will tell you have a bladder infection, or you have an interstitial cystitis, or in men, you're suffering from chronic prostatitis and prostadynia. And in neuropelveology, we'll say you have a pathology of the nerve in charge of the orthopedic function, urologic function, gynecological function. And in somatic pelvic pain, you have two possibilities. You have an irritation of the nerve, so you have no neurologic disorder, or you have damages of the nerve. And when you have damage, for example, the sciatic nerve, you will present some Trendelenburg gait or a foot drop. For the bladder, maybe you will be unable to empty your bladder, or you will develop urinary and fecal incontinence. They are all symptoms, the all together are, uh, are typical for pathology of the punatal nerve. And then I said further diagnosis. Because if you're going, for example, by a gynecologist, gynecologists will say, okay, you have vulvar pain, that is my job. But your back pain, your sciatic pain, your issue with the bladder, that is not my job. I am a gynecologist. And if the gynecologist try to help you with some topic, some cream, some antibiotic, and in the end, nothing help, then it will be much easy for you or for the doctor to bring you in the psychological corner. And that is what I call the patient's wondery. So you will get a diagnosis, depression, psychosomatic, or a beautiful name, syndrome like CPPS, vulvodynia, IC, PBS, all beautiful names that are not a pathology. It's not just a name to say, by the through, you're suffering from something, you have pain, but I don't know what you're suffering from. Sexual conditions, that is always the worst. In a woman, directly, you will have sexual disorder, you have sexual trauma, and you have to be aware a very, very typical sign that maybe you're suffering from pelvic nerve issue is that all previous treatment fail. You got a lot of antibiotic, antidepressive, anticholinergic, painkiller, whatever, and nothing help. And that is typical. When you're sitting in front of a doctor and the doctor don't know what you're suffering from, and all previous treatment fail, then think it could be a pathology of the pelvic nerves. And why? It is very important to treat the cause, because painkiller will help you only for 1 hour, one day, or for temporary time. Um, if you treat the symptom but not the cause, it's a treatment on long term. A painkiller will never treat the cause, but the symptom itself. And then you will forget to look for the cause, and maybe over year, you will take painkiller. You will become much more independent from the painkiller. You will develop more and more side effects, and everybody will miss the cause of the pain of the pain. And of course, with pain medication, you will become dependent from this pain medication. You have the risk, because of this dependence and what we call tolerance. At some point, you will take much too much painkiller, what we call overuse or even misuse. It will destroy your life. It will distort your mind. You will get a very, very high, strong psychological impact. And the cost will increase a lot, because medical treatment of the symptom, it's an ongoing treatment for the rest of your life. It will use a lot of cost. And one of the main problems of this direction is what we call central sensitization, or what I call the pain memory. Your brain will fix, you will have, the pain will be fixed in your brain, and it will be very, very difficult to take this brain information from your brain out, with huge emotional impact, widespread pain. That means it's even you have to touch you somewhere, and you will have suddenly a lot of pain, because your pain vegetative nervous system is on the high level. You will feel pain for everything. Too much light, too much noise, too much touching, and you will have more pain. And that is what we call the central sensitization, and it's very, very, very difficult to deal with this pain memory. So the neuropelveologist will try to find the cause. And the main step in neuropelveology, and for that, you need, by the through a certification. You have to look for an ISO level 3 certified neuropelveologist with experience over years. And these neuropelveologists will try to find out which nerves are affected and bring the information of pain to your brain. That is the first step. Which nerve? So the neuropelveological diagnosis is by the through a neurologist diagnosis. So when you're coming and you say pain, the diagnosis will be not directly you have endo or you have an affection, but to say you have a neuropathy from this nerve in this location of your pelvis, and this pathology is an irritation of the nerve or a lesion of the nerve, because the treatment will be not the same. And first, the second step will be to find out what could be the cause of this nerve irritation or nerve damage. Is that endometriosis? Is that a tumor? Is that a lesion of the nerve due to a previous surgery? And then first, you will be able to treat the patient, because the treatment will be adapted to the cause and to the nerve, which nerve, in which location in your pelvis. And that is very important, because your pelvis is plenty of nerve. It's like in the brain. A neurosurgeon will never go blindly in your brain to see what is going on there. The neurosurgeon will know exactly what you have to do in your brain. He will know that your problem, your aneurysma, your tumor is here on the left or in the back. He will know exactly how to reach this tumor. In the pelvis, it's exactly the same. It's not enough to say, I suppose you have an issue with the nerve, let's do a laparoscopy and to check the nerve. No, to just check the nerve, you can make everything even worse. You need a neuropelveologist, a certified neuropelveologist who know exactly what you have to do. And that is what we call the ISO. So, and I think we are on the end of our lecture, and I thank you very much for your attention. Keep healthy, enjoy your life, and see you the next time for the next lecture. Bye-bye.